the Department of Conservative Dentistry and Endodontics, Bangalore Institute of Dental Sciences, in association with AS Karnataka. Let us first pray to the Almighty as we commence today's session. So, today we have two eminent speakers amongst us. They will be throwing light on two interesting topics. The first lecture is on the management of MB2 canal, followed by the lecture on lasers in conservative dentistry and endodontics. I hereby request our senior professor, Dr. Ashish Shetty sir, to invite and address the first guest speaker for the day. A humble request to all the participants to mute their audio and switch off their video during the session. In the end of the session, we would be having an interactive question and answer round. So kindly forward us your questions in the chat box for the speakers to solve your queries. Thank you. Over to you, sir.
Yeah, thank you, Ruchika. On behalf of Bangalore Institute of Dental Science, the management, our chairman, Dr. Katuri Subbarao, our directors, Dr. Swaira and Dr. Siri Krishna, our principal, Dr. Vinay Pai, my dear madam, Dr. Ramya Raghu, and the entire team of BITS, we extend a very warm welcome to you. So this is the fifth session of a masterclass series, and we're very happy to be able to do this continuously. Keeping the lockdown at bay. And today we have two excellent speakers. So to introduce the first speaker, I'd like to start with a quote by the famous Greek philosopher Aristotle. He says, "If we are what we repeatedly do, excellence then is not an act but a habit." Our first speaker, Dr. Narasimhan Bharadwaj, is a very embodiment of this statement. His untiring, unwavering focus and dedication to his craft has made him one of the most renowned endodontists in the country today. Now, I know Narasimhan for a very long time, so I'll give you a small personal tidbit what happened between us. As I jog down memory lane, it was 2007 where we conducted a very big event called the first South Zone Rotary Symposium. It was big because we had who's and who's of dentistry attending it. We had the president DCI. And as it happens in all functions, when you have a huge inauguration, the schedule goes haywire. And Narasimhan lecture bears the brunt of this. And Meena madam pushes me in front to tell him the good news. So he gets really pissed that it's post lunch, and he makes it a point to even mention it during his lecture. And finally, Dr. Meena, comes between us and puts things to rest. Of course, we did break ice over dinner and good drinks. And what I understood during that time is here is a guy who's very, very passionate about his craft and a very prolific clinician. And most importantly, he's a very dedicated teacher who wants to disseminate information at the right place at the right time. And I think my observation has been steadfast because his journey has been incredible. He passed out from, I think, MGR Medical University, both his BDS and MDS. He got the best outgoing postgraduate student award. He's currently the professor in Savita Dental College. And most importantly, he runs this unique dental training center called the Access Dental Institute, for which he's the director. And this center runs a fellowship certificate program, which is affiliated to the University of Malaysia. Now, his interest is in microscopic endodontics, especially retreatment and instrument retrieval. He holds two copyrights of original invention category, one being the burrowing platform technique for instrument retrieval, and the other is reverse power focalization, which I think he's going to talk about it today. And he runs the first super specialty training institute in Savita Dental College for microscopic endodontics. It's a fellowship program. In addition to this, he's been giving lectures, delivering lectures all across the world. I'm told almost 400 of them. And he has 6 best original research papers. And with all this, his hands are full, but he does also something to the society. And that is what, I really appreciate. You're giving back to society by being managing trustee of a charitable trust. And that is fantastic. And, this is something all you PG students should look up to by doing something in your own way to give back to society. Narasimhan, we have been third time lucky, like I mentioned. A warm welcome from all of you. The platform is all yours.
Thank you. Thank you so much, Ashish. Thanks a lot. Yeah. Is my screen visible?
Yes, sir. Yes, sir.
Yes.
Yeah. Okay. So first and foremost, thank you, Ashish, for that nostalgic moment that you shared. It was actually exactly 2007, and I don't know whether Dr. Meena ma'am is also here amongst us. And I was the youngest speaker at that time, and it was one of my highest, biggest forums. And I was all geared up, and they said that my lecture is at 11:30, which is the peak hour. Then later, as Ashish rightly said, things went haywire, and they said that at 2 o'clock exactly post lunch, I got cheesed off. In fact, I was in a hot argument with Ashish when things went off. And thank you, Ashish. Thanks a lot. I will never forget you in my life. Thanks for that wonderful introduction. Thank you very much once again. So, my heartfelt thanks to Meena ma'am and team for giving me this opportunity to be a part of this prestigious masterclass series. I've been hearing good news about this masterclass series where it comes into the forum of a lot of good speakers and good quality speakers. So thank you, Ramya ma'am and team, for giving me this wonderful opportunity. And this was like a few days back when I requested Ashish to just share a picture, and he shared a picture, and I was just casually, I didn't go through fully, I just casually flipped through the picture, and I messaged him, I want a picture with Ramya ma'am. And then later I realized, as I was going through closely, Ramya ma'am is one among the camouflage like a postgraduate student. I deleted that message. Ashish, if you see in your WhatsApp, there'll be a deleted message. It's that only. So this is the wonderful team actually. And Ramya ma'am, you're just camouflaged as a student. I can hardly make out you as a teacher. So thank you once again, ma'am and Ashish and team, for giving me this wonderful opportunity. Whatever I am today, I owe to this great man. It is customary that I always introduce my teacher before telling who I am, because whatever I am today, I want to put it in the backdrop of my teacher who has made me what I am today. And this is my designation, which Ashish just mentioned a few minutes back. The comeback is always greater than the setback. So I am, forget about the passion and all those things. I want to ascertain the young mind and the young students who are actually listening here that you are into one of the best professions in the world, and endodontics is a fantastic profession. And if anyone is going to tell you that COVID is going to have any kind of a stop, I beg to differ, because even after last year's COVID, by God's grace, we were working throughout. And after the COVID was settled, there was a beautiful surge what we saw in the patients. And then, of course, now there is this lull. And definitely, I would say that the comeback is always greater and stronger than the setback. And we are in one of the best professions in the world. There is absolutely no second thoughts about that. Now, today, what I'm going to be talking, I have divided into two small topics. The first aspect was the microscope focusing, and the second aspect is the MB2. So I just want to make it clear that normally any webinars of mine, I generally speak for about 45 to 50 minutes and then followed by about 10-minute questionnaire. So I'll stick on to the same timing here. Now, when we start the first aspect about microscope focusing, I just want to recollect the year 2011, when I first entered into microscopic dentistry. I got my first microscope, which is the Siler, and this is precisely what I experienced too. And I'm sure most of you watching this particular slide, and most of you are who are into endodontics or microscopic endodontics, will be familiar with this side, because initially, when you start working on a microscope, the maximum tenure that you spend is focusing. So the maximum time what you spend is focusing, because you put the patient and then you keep on meddling, you try so many things. There is no exception. There is no exception to that, including me. I was like meddling, 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 meddling. Okay. And then finally at one point you get a focus and then you start doing, and then you just lose the focus a little bit and then you start. So I would say the maximum focus, the attention you get is in the focusing of the microscope rather than the clinical work. I'm sure most of you would have experienced this. Now, Now, to understand, to make you understand this aspect, why is it we are facing this difficulty? You will have to understand that in photography, like for instance, I'm just giving you this as an example. There is something which is coming. Requesting to note the shared content. Should I approve or should I decline it, Ashish? I'm getting some.
What are you getting?
I'm getting Alsa Mariam Varghese requesting to annotate the shared content. Decline, approve.
Just decline it. Who's this?
Okay. Yeah. Sorry about that. Yeah. Okay. So now, sorry. Yeah. So I just want to give you a small example. Why I'm talking about this is basically because in photography, you have something called still photography and you have something called as just hung a bit. 1 second. Yeah. Yeah. Am I audible, Ashish?
Yes, loud and
Yeah,
clear.
yeah. So, yeah, yeah. Sorry for the interruption. Something happened. Like, no, not here. So there's something called still photography and something called motion photography. Now, even though they both are photography, if you notice, there is a complete difference in the still photography and motion photography. The settings of your camera, the way in which you photograph, the distance from the object, the shutter speed, everything is completely different, totally different. Now, similarly, if you notice, magnification in medicine and magnification in dentistry, if you compare these two, now why I'm giving you this comparison is basically because we are actually followers of people who are using magnification in medicine. So whatever literature is available in microscopy and whatever literature is being taught to us is basically taught to us from medical sciences. Now, I'm sure you must be aware that people in ENT, people in ophthalm, people in vascular surgery, people in neuro, all of them use microscopes. Now, the same modus of operandi, what is being taught to them, is exactly given taught to you. So, this is basically where we have derived how to focus in dentistry. But unfortunately, if you notice, magnification in medicine is completely different. I would probably put to this as a still photography where the subject is completely static. Whether it is ENT or ophthalm or neuro or vascular or any specialty in medical, if you notice, most of the procedures, I would say 99.9% of the procedures are done in the operation theater where the subject is completely anesthetized. Whereas in dentistry, if you notice, there is a huge difference. Why? Because ours is more like motion photography, where the subject is dynamic. I'll give you a small example. Is it possible for us to stay without moving anything for just 2 minutes? It's not possible. It is absolutely not possible. So, this is the biggest challenge that we face as dentists when we focus on a microscope. What is being taught to us and what is being told us in literature is basically the same modus of operandi what is being taught in medical. But unfortunately, the subject in which we are working is totally different because in a medical science the subject is static, whereas in dental the subject is dynamic. Now, I'm sure most of you who are into microscope will know about this term called as parfocaling. Now, this is the heart of microscope, which means this is the funda, the basic funda by which you can focus a microscope. Now, it says it is a step which you achieve wherein you are focused at all magnifications. Now, the word par in English is equal. Focaling means at all focal lengths. So whether it's 0.4 or 0.6 or 1 or 1.6 or 2.5, you are completely focused in all the magnifications. Now this is called as parfocaling. Now, what is the importance of this parfocaling is when you focus in a higher magnification, the subsequent lower magnifications remains autofocused, which means if you're focused in one, you will be focused in one 0.6 and 0.4. If you're focused in 1.6, you'll be focused in 1.6, 1.6 and 0.4. So if you're focused in 2.5, which is the highest magnification, you are focused in all the lower magnifications. This is the funda of parfocling, and this is what is being taught to us. Now, if you notice, this is what every literature says, this is what every speaker says, whether it is national or international. You go to any forum, this is how they teach you how to focus a microscope. Basically, you start focusing at 2.5 and you get a proper focus. The moment you get the focus at 2.5, they say that all your other magnifications are focused. It sounds very simple. It sounds very simple. But you touch your heart and tell me, how many of you would be focusing like this, find this very simple on a patient? It's extremely challenging. Extremely challenging. To get a focus at 2.5 is extremely challenging for a dynamic subject. And this challenge is amplified if your microscope is not having a feature of vario. Vario means you can adjust the varioscope. Okay, I'm not going into the details of microscopy. I'm just telling you, people who are using a microscope, you'll know what is a vario. A vario is basically nothing but a added lens which gives you a little bit of additional focus in a particular focal length. Now, if your microscope does not have vario, and if you're working on dynamic subjects, this parfocaling or focusing at 2.5 is not all that easy as you are doing it in a training center. This is what I want to emphasize, because in a training center, you're keeping the model down and you're focusing. The model is static, but on a patient, the patient is not static. So this is just, I'm giving you an example. At 2.5x, this is how you're focused. Whereas at 0.4x, this is how you're focused. This is how you're focused. So now what literature teaches you is, you get yourself focused in the highest magnification, which is 2.5, as a result of which all the lower magnifications you are completely focused. This is what literature teaches you, and this, to be very frank, is not all that easy as it is explained. So now, what is my take? What did I do? Now, what I did was, I completely altered this style into something called as reverse parfocaling. So what do you mean by reverse parfocaling? The first thing is, you start focus on the lowest. According to literature, it is the highest, which is 2.5. So what I'm telling you is, you start focusing on the lowest, which is 0.4. At 0.4x, it is like a child's play. Anyone can get the focus very fast. Very easily, you will get the focus at 0.4, because 0.4, you have a huge field. Now from 0.4, what you do is, you step up to 1x. I repeat, from 0.4, you step up to 1x. Now when you step up to 1x, all you will need is a very, very, very minimal adjustment. You will very minimal adjustment, you will get focused on to 1x. Now, when you get this step out, what happens? As I told you, as a rule of parfocaling, when you're focused on a particular magnification, whatever lower than that will stay autofocused. So when you're getting focused at 1, you're focused in 1, 0.6 and 0.4. So at 3 magnifications, which is 0.4, 0.6 and 1s, you're already focused. And let me tell you, dear friends, let me tell you once again, dear friends, 90% of dental work, I would say even 95% of dental work, including your endo, can be completed in these 3 magnifications. Your access opening is 0.4. The moment you open the access to on the pulp chamber, you are again 0.6, and on the floor to trough to find the canals, you are on 1x. And anything outside the tooth, whether it is resto or crown or anything, it is between 0.4 and 0.6. So 90 to 95% of dental work is completed in these 3 magnifications. So I take out from my mind 1.6 and 2.5 at all. I don't even think that they exist. I finish everything with this magnification. Now, where will you need this 1.6 and 2.5? Only in very specific procedures where you are working inside the canal beyond the middle third. I repeat, where you're working inside the canal beyond the middle third. Supposing if you have an instrument retrieval, if you have a ledge, if you have a perf or a strip perforation which you have to manage within the middle third or the apical third, only in such procedures you will need 1.6. And trust me, 2.5x is merely for documentation. is merely meant for documentation. If any endodontist or any microendodontist says that I'm comfortably working in a 2.5x, it means it's a blatant lie, or he or she has never used a microscope. So at 2.5x, it is not easy for you to work. 2.5x is just what I do is I specialize in instrument retrieval. I do a lot of retrievals. Predominantly, I work at 1 or 1.6. And at 2.5, I just flip to see what is it. And then I flip back to 1.6 and start working on my instrument. Okay, so your work actually finishes at 1.6. 2.5x is merely for documentation or taking pictures. So my simple concept is the least what you're going to be using is a 2.5x. Why you should struggle to the maximum as a beginner to start focusing in 2.5x? You don't need at all. So you start at 0.4, jump to 1, and you're done. So 0.4, 0.61, and you're finished. And as far as camera power factoring, supposing a lot of people ask me this question, sir, I fitted with a beam splitter, I fitted a camera. What I see is clear, but what my camera sees is not clear. Now, how do you parfocal that part? Just remember, parfocaling of camera is done only in 1x. Don't do it anywhere else. Keep it in 1x. You first see and then make sure the image is clear. Then you adjust the camera and you're done. That's how parfocaling of a camera is done. Parfocaling of a camera is done only in one magnification, which is 1x. So I just wanted to repeat, highlight this part. And this is my copyright, and this is called as the reverse parfocaling technique. So whoever comes here to me and all my MFM, this is what we teach, and you can ask them how easy it is when they switch over to reverse parfocaling. That to focus a microscope is just a child's play. You don't have to actually struggle with the conventional literature technique of focusing at 2.5 and then coming back. Now we go to the second part of my lecture, which is MB2. Now, very rarely with magnification, very rarely I don't get an MB2. Most of my first molars and sometimes almost 50% of my second molars, I get an MB2. Now, how do you chase the MB2? So first and foremost, a lot of PGs, a lot of students come and ask me, sir, to start tracing an MB2, how do we start? Do we need a microscope directly? I'll tell you very frankly, you don't need a microscope to chase MB2. If you have a loop, it's good enough. It's good enough. Microscope will be great, no doubts about that. But if you have a good loop, a chasing of an MB2 is good enough. So it's not just the magnification which is going to help you in chasing MB2. It is something else also. Now I'll put it in order. What and all you will need as a postgraduate student, as a clinician, if you want to chase your MB2, if you want to trace your MB2, what is that you require? First and foremost, you need some specialized files. I am not promoting any company here. Whatever specialized file you suits you, a C plus could be fine, a C pilot could be fine, a D finder could be fine. Any specialized file is a must. Now, why is it? Because a normal size 10K file, the tip is very, very fragile. By the time you put your tip near the MB2, the tip bends and it frustrates you. You use a lot of MB2 so that you start wasting your MB2. I mean, you start wasting your files. So you need some specialized files. Now, these are files where the tip is electropolished and the tip is made a little stiffer. And a good DG16, a good DG16. So these two are first important parameters, specialized file and a DG16. Now, the second most important thing, I put my foot down and tell you this. The second most important thing in MB2 tracing is you will have to have ultrasonics. Let me put it in one line. If you don't have ultrasonics, your tracing of MB2 is by luck, is a fluke. I will tell you, is just a fluke. If you're getting MB2, okay, out of DG16 and things that you got it, it's just by luck. It's not by science. If you want to be very sure in this particular tooth, I know there is an MB2 or I know there is no MB2. If you want to be concrete, if you want to be really, really clear cut, definitely you need ultrasonics. So there is no MB2 chasing without ultrasonics. Now, ultrasonics, I would personally recommend Action for the simple reason because most of the endodontics, the tips that are available in India are Action compatible or satellite compatible. Whereas EMS is also good, but unfortunately, EMS range of tips is not available in India. So that is why I personally prefer a satellite ultrasonic. And now the tips that are used for MB2, I've put there on the screen there. you need a size 3. Now this is manufactured by two companies. One is Dentsply Sirona, they're called Startex tips. Another is your CAP or cap tips from Satellite. Both are same, anything of your choice, and both are compatible with Satellite scale. So it is StartX 3, StartX 5, and then you need a ET20D, endodontic tip 20 diamond coated. D stands for diamond coated. So these are the three tips that you will be needing to trace a MP2, and the same thing holds good for tracing of middle mesial as well. I'll show you a case of middle mesial tracing as well. Now hereafter I'll show you all the videos where you can see me using these three tips in a sequential fashion so that you are very sure that you are able to trace the MP2. So I repeat, dear PG students and dear clinicians, if you want to be very sure of tracing MP2, these are the basic armamentarium that you should have. You should have a specialized file, you should have a good DG16, and definitely an ultrasonic followed by at least these three tips. At least these three tips of StartX3, StartX5, and ET20D. And all this will be complemented. I use the word complemented by a microscope. So if you have a microscope, the precision what you get from all these things is going to be exaggerated. And so it's going to be fantastic if you're going to be using it under a microscope. So this is the fundamental chart that you usually need to trace a MB2. Now I'll show you a few clinical videos. I think some videos I've already shown. Okay, a few of them are new. So this is one case where there is a complete floor calcification. Now the first step what I do is I use a StartX 5. I use a StartX 5 to trough the floor. I trough the floor by using a StartX 5. Okay, completely trough it so that the floor gets cleared. Now, once the floor gets cleared, you can see here that there is absolutely no trace of an MB2. There's absolutely no trace of an MB2. So what you do now, you take your StartX 3 and start troughing from the mesiobuccal to the palatal up to the middle third. Don't go beyond the half of the half groove. You can see that a small groove is being created between the mesiobuccal and the MB2. Now there what you do, use a DG16. Use a DG16 and try to get a catch. You can see there, use a DG16 and try to get a catch. Now once you get the catch, then you use a specialized file. Here in this case, I'm using a C pilot. What I'm using here is a C pilot. Okay, use a C pilot file. I'm telling you, you can use C plus, C pilot, define, all the same. Okay, so you can use a C pilot file and then I use my SX to gently enlarge my orifice. I use my SX ProTaper SX Gold to gently enlarge my orifice. And that is how you trace your MB2. That is how you trace your MB2. I'll show you a few more cases as well. This is the current recent case. This case I have not shown before. Now see here, same way. When you see a pulpal stone, you start troughing the pulpal stone by using a StartX 5. That is a StartX 5 what I use there. Start troughing. Troughing means you just rub on the floor. Okay, so as you rub on the floor, the pulp stone which is attached to the pulpal floor starts moving. And then the second step, you take your StartX 3 and then from the mesiobuccal to the middle, you start creating a groove. In the same way, take your DG16, and then you go for the catch, where you get the catch. And once you get the catch and use your specialized file here, okay, and that is my MB2, which is being traced. And use my SX ProTaper SX Gold, just gently enlarge the orifice. And you can see that that is my MB2 tracing. That is my MB2 tracing. Now here I'm just showing you a small case. This was a retreatment. This came to me and it was a short obturation of MB, mesiobuccal, and there was a periapical pathology with symptoms. So I knew that the previous operator had missed the MB2. So I went in to start and tracing my mesiobuccal too. Removed all the gadapacha, went in for a full retreatment. And this is actually a very tricky and funny case. I think I have presented this about 4 or 5 months back to a forum. And then I start using my StartX3. I start using my StartX3. Start using my StartX3. Then same way I use my DG16. Start using my DG16. And the moment I get a catch of my DG16, I use my specialized file to go in and negotiate. Now here, as I was trying, I could get a catch. My file went in a little bit, but if you see what's happening here, my SX is actually bending. My SX is actually going towards MB2, but it is actually bending and going into MB1 itself. If you notice there, the orifice is just merely getting widened. The orifice is just merely getting widened. So now here, if you can see that the orifice is little wider. So what I did was, that is a micro brush what you use. That's a micro brush what you use to actually curve. So now what I do is, I use my ET20D. Just note down, dear students who are watching, this is ET20D, because the very thin tip which goes inside, which is a diamond coated tip. So I go in and then I start troughing with my ET20D. I gradually start enlarging, and to my surprise, I see that the division of the MB2 is beginning about 8 to 9 millimeters into the canal. You can see that. You can see that. That is my MB1. That is my MB1. And that is my MB2. So it's not necessary that the MB2 should arise on the top, on the floor level itself. There are possibilities that the MB2 will start dividing at the middle third of the canal as well. That is MB1 and that is MB2. And this is at 2.5x. What you're seeing here on the screen is 2.5x. As I was working inside, you could see that I was in 1x. So you can appreciate here that you can see from the X-ray that up to middle third, it is just one canal, and from the middle third, it divides into two, which is a reverse Y pattern. Generally, we have heard of a Y pattern, which is mesiobuccal and mesio MB2 starting like this and converging and having a common exit. Now, this is a reverse Y pattern where it is starting as a single canal, and then at middle third, it divides into two, and you have a MB1 and a MB2. Then I'll show you a case of selective retreatment. Even this case I have shown in my previous lecture. So those of you who have watched it, just be a revision. Now this is like, a zirconia crown, wherein the patient came to me with a specific complaint of pain and it was referred to me for a retreatment. Now this is called selective retreatment, wherein if you're very sure that the distobuccal and the palatal are intact, with the gadaparcha intact and there's no lesion, you can do a selective retreatment provided you don't expose the other canals. So you start exposing only the mesiobuccal and you trace selectively the MB2. You can see the gadaparcha there, that is the MB1. Now I don't disturb that at all. I just go to my MB2, I trace my MB2 separately. You can see that I trace my MB2 separately, and that's my MB2, and the gadaparcha on the top, that is MB1. You can see that MB1 is there, and below I trace my MB2. That's my MB2. Then I use my bioceramic sealer. This is BioRoot RCS. That's how you use your bioceramic. All my retreatment cases, I use a bioceramic sealer with a single cone obturation. And then remove my temporary filling, bond it, And see this size of my axis opening. It's the size of the micro brush. It's exactly the size of the micro brush. And then inject your flowable composite. Here in this case, I'm using a SDR. You can use any flowable material. And then on the top, I pack it up with my composite and restore it back. So my zirconia crown is intact. I've just gained access only onto the missed MB2, selectively retreated it, and I've restored it back. Now this is possible only with microscopes. If you're going to make a big axis opening, then you can't do a selective retreatment. You can see that the size of the axis opening is exactly 1 millimeter. Is exactly 1 millimeter. That is my obturation. You can see there that the mesiobuccal 2 is separate, having a separate exit. Just showing you another case where 1/7, most of you think that in 1/7 mesiobuccal MB2 doesn't come. You can see that it's 1/7 MB2 having an independent exit. Now these are cases where if you miss, you're asking for trouble. And this is a very new case which I did, which I have not presented. This is middle mesial tracing. I'm using a ET20D. I prefer a ET20D for a middle mesial tracing for the simple reason why, because the isthmus is very thin. So you can see that I start using my ET20D. So what I do is, so I trough with my ET20D between the mesiobuccal and the mesiolingual, and then as I trough, I gain access and I trace my middle mesial. That is my middle mesial using my same specialized C plus C pilot file. That's a C pilot file, and then I enlarge the orifice using my SX. Yeah, and now that is my middle mesial. You can see that that is my middle mesial. That's my middle mesial. Now, which are the cases that you have to trace your middle mesial? If you ask me a question, all cases. All cases, what I do is I use my ET20D. I trough between the mesiobuccal and the mesiolingual, and then I clear the isthmus. Once the isthmus is clear, if there is middle mesial, you can see the opening beautifully. In fact, it's very easy to identify a middle mesial compared to an MB2. The moment you trough between the mesiobuccal and the mesiolingual, if there is a middle mesial, it opens up. If there is no middle mesial, you can evidently see the isthmus being continuous. So you are very sure that the middle mesial does not exist. So almost all my lower molars, I open the axis, I trace my canals, and then I start troughing with my ultrasonic. So to me, I don't do endo without ultrasonics. That's why I told you in the beginning itself, ultrasonic and magnification are my two hands. So without magnification and ultrasonic, there's no endodontics for me. Almost all my cases, I use my ultrasonics to trough and check to clear the isthmus to see if there is any anatomical configuration present. So now what is the flip side of magnification? The flip side of magnification is nothing but positive addiction. Positive addiction. So now recently it happened. One of my very good friends said that, is it possible for you to come for consultation to my place? Is that possible? I said, unfortunately, since you don't have a microscope, I cannot come to your place. It's not possible. So it is a positive addiction. Once you start seeing things with a loop and a microscope, now I can't even do a diagnosis without a loop. So that is the flip side of magnification. And my journey to addiction, as I told you, first I started with a magnifying lens, then I started with my loop. Okay, and then the first loop what I got is a Hein, then now I use a Calzis prismatic. Now my 2011 I started my Siler. The right corner machine is what you see is the Siler, and then 2014 I bought my Sanma, and then in 2017 I got my Calzis Extero 300 microscope, which is a specialized microscope from Carl Zeiss, and this is the first microscope installed in India is in my place. And this was 2020. Last year, there were some funny days where I had to wrap up myself like this and work on a microscope. And of course, that was short-lived because I found it very, very tiring. Now, I don't, to be very frank, I don't use PPEs and all. And this is what I use, what I'm sitting here with. That is my drips. I just use my scrubs and I start. This is how we work now. So thank you once again, and this is the module that we use. I mean that we do. That is the 2 days magnification module for beginners. And this is the list of microscopes which I have in my training center. A lot of my friends and a lot of my colleagues say that I've gone mad because this is about I have about 7 microscopes I have in my training center with 7 brands. And this is the short day 2 days module. And this is the one that Ashish was mentioning, the super specialty program, the master's fellowship in microendodontics, along with Savita University. And you can see in the picture there, Dr. Meena ma'am, who was my first batch student. I was really lucky and proud to have, like, been associated with ma'am. She invokes a lot of confidence, and that is Vivek Hegde, who came as an examiner for the first batch, and that is Dr. Deepak Nallaswamy, who was actually giving the fellowship, the super specialty certificates duly affiliated from the Savita University, the MFM. And the second batch, in fact, is just under progress because of COVID. We just paused it. And Dr. I don't know whether ma'am is there, Dr. Sandhya Kini, who is the head of the department of Manipal, is our second batch student. So this is the MFM program that we do with Savita University. And this was the day when I truly felt blessed. The person who crafted me, whatever I am today, is the person who is Dr. Parameshwaran sir. And a couple of years back, when he called up and said that, can I come to your training center? Will you teach me microscopes? And I had no words to express when he came. I just fell in his feet and I took his blessings. And more than me teaching him, he's 80, 80. Imagine at the age of 80, somebody has the passion to come and learn microscopes. And this is my family, my endoline, and for whom I exist. And thank you very much for giving me this wonderful opportunity. Yeah, exactly 45 minutes. I stuck to my time so that we can have a 10 to 15-minute questionnaire.
Yes,
I
sir.
wanted to be very specific at 45 minutes, Ashish.
So thank you so much,
You
sir.
could have gone on, no problem.
Now, generally, what I've observed in webinars is after 45 minutes, there's a lot of distraction in the brain. Generally,
Yeah.
we tend to take our WhatsApp and start looking at it. That's because I myself have done the same thing. So, in the last webinars, I've realized that the maximum capacity where you can hold someone glued to the screen is 45 minutes.
Yeah, that's true. That's what I think Ramya madam agrees with you wholeheartedly in this.
Sir, sir, can you please stop sharing the slide?
Yeah, I'll do that now. So, I specifically timed it to 45 minutes exact.
So thank you so much, sir. As always, you have been phenomenal. You made this topic look so easy. Thank you so much for
Thank you, ma'am.
sharing your knowledge with all of us.
Thank you, ma'am.
And so, uh, I- so as a token of appreciation, we would like to give you an e-certificate.
Thank you.
So the
Thank you so much.
e-certificate, yes, sir. The e-certificate will be sent to your email address. Kindly accept it, sir.
Thank you. Thanks a lot. Thank you, Ramya ma'am. Thank you, Ashish.
Yeah.
Now we have the question and answer round. So over to sir and Ashish.
Yeah. So one of the first questions, hi, Narasimhan, that was fantastic presentation. And like
Thank you.
Ruchika said, beautifully phenomenal, and you make it look so easy. I think, it's really commendable the kind of work you do. And your passion is, of course, evident. I've heard from Meena Madam that one thing she said about when we're discussing that, I called her that, will you agree to talk on me? See, that's the new thing that me and Ramya Madam talk. Will they agree? So, we have been fortunate that whoever we have asked, whether it's national or international, have agreed. So those who don't agree, it's their loss now. So we can do it. Anyway,
Thank
thank
you.
you so much. It was fantastic. So the first question that you have mentioned, you have shown a case where the root canal divides at the middle portion, okay, and then bifurcates, and you get that Y shape. Correct?
Yeah,
You would,
yeah.
okay. So the question here is, how easy when it divides in the middle to fill such a canal, whether with microscope
Exactly.
or without? Yes.
Now, first thing is definitely you will need magnification. There's no doubts about that because unless you see the bifurcation, you will not be able to work on it. And how you will obturate is you will fit the Gadaparcha and you will have to remove exactly at the point of bifurcation. You have to use a like a touch and heat or some kind of a plugger, Buchanan plugger, where you heat it and you remove the excess Gadaparcha exactly at the point of bifurcation. Only then you will be able to fit the second Gadaparcha. Otherwise, the two Gadaparchas will not go together. So one GP will be placed and then removed, and the second GP is the one which comes up to the cavo surface. That's how you go for obturation. That is one option. The second option is to be more easier. You have some injectable bioceramic sealers, like your Seal, for example. Now, all you need to do is just place it over there and you inject it. Okay, and use a lentillospiral and make sure it's spread properly. And then the second canal, you can go in for a gadapacha. So one part of the obturation will be fully bioceramic, and the second part of the obturation will be with gadapacha.
Okay. The next question you have, what is your opinion on Ninja Access?
Ninja Access is something which I started practicing initially, but to be very frank, it's almost now 4 5 years I'm into microscopy. What I've observed is this, again, I don't have any studies for it. Whether you put a Ninja Access or whether you put a wide axis, when you don't give a coverage restoration, I won't say a full crown because I don't do a full crown nowadays. I go in for an overlay, a tabletops. But when you don't give a coverage restoration, definitely the cusp separates. Then the cusp separates, whether irrespective of whether the axis is so small or so big. Because I myself have given lectures 4 years back that if you do a very minimal axis opening, you don't need to give a coverage restoration. But now I am actually redoing my own statements because I see my own patients, Ninja Axis, a premolar fracture. The cusp is the tooth is fractured. So with the kind of forces that what Indians we have, I don't believe in the concept of when you do a small axis and when you go to core, you don't need a crown. I beg to differ from that. I mean, as I told you, there's no studies, but what I've seen in clinical practice, at least 4 or 5 of my own patients, there is cuspal fracture. So I stopped doing the just not giving the crown. So what I do now, if the contact is intact, I just give an overlay. I give an Emax overlay so that I cover the cusps. So definitely you need a cuspal coverage restoration post-endodontically. This is my take. So when you're going to give a cuspal coverage restoration post-endodontically, it really doesn't matter whether it's going to be a Ninja Axis or a convention, or you don't definitely go for a conventional axis of like a big axis. Okay, but a normal axis versus a Ninja Axis, the outcome is not very great different.
Okay. The next question we have, till what depth do we need to trough in order to get an MB2 or an middle mesial canal?
Exactly, this is, I was just thinking, I wish somebody asked this question. Whoever asked this question, a big salute.
Sampath
Okay,
Kumar.
okay, great, fantastic question. The maximum depth that you should go is, you can see that something like a V. When you have a trough, you will have something like a V which is going there. When you go and keep on seeing, the maximum depth is about 1.5 to 2 millimeters. Okay, 1.5 to 2 millimeters. Beyond that, it's a risk of perforating. So up to 1 point, if at all, if you have a canal, definitely within the first 1.5 to 2 millimeters, it will open up. So what you do is you trough it. But even if you don't see the canal, you take a DG16 and start probing. See whether you're getting a catch. Once you get a catch, then it's that catch in which you have to widen it by using a specialized file and your SX. And to get that 1.5 to 2 millimeters, I would personally prefer a ET20D, which is a diamond coated, because it's easy. Because the tip of the diamond coated instrument, if you have seen a ET20D, is a very, very sharp one. So it's easy to trough with the ET20D, even though literature says it's better not to use a diamond, to use a StarTex 3, like a stainless steel one. I would prefer to use a diamond, of course, with caution, because when you use a diamond, it's very easy. You can actually trough it to perfection.
So, yeah, thanks. So the next question is, does the anatomy of a crown give any hint of the presence of an extra canal? And yes, if yes, how in the case of MB2 and mid-mesial canals?
Definitely not. To my knowledge, the anatomy of the crown doesn't give. The anatomy of the pulp chamber gives to a certain extent. The moment you open the axis, you see that there are two things that you observe. You see the height of the mesiobuccal in relation to the distobuccal. If the height of the mesiobuccal is little higher compared to the distobuccal, in most of the situations you get an MB2. That is one clue that it gives you. The second important clue is something called law of volume. When you put your file, if the mesiobuccal 1 and the distobuccal is almost of the same volume, you generally don't get an MB2. Whereas if the MB1 is more thinner, when you put your file, you can easily, with your tactile, you can feel. Your
Yeah.
distobuccal will be relatively bigger, whereas your mesiobuccal will be relatively thinner. In that case, invariably you will get an MB2. I hope I'm right, Ramya ma'am.
Yes,
You are, you
yes.
are. Yes. There's one more question asked again. They would want you to explain that obturation of MB2 again, please.
Okay. See, as I told you, there are two methods of obturation of MB2. One is till the point of bifurcation, you put the GP, that is with the sealer, and you need some very good long tips which can heat, like your touch and heat tips or your calamus tips or your elements tips, which can go to that point of intersection, that is the point of bifurcation, and remove the gadaparcha. So then the other canal can be obturated in a straightforward manner. That is one option. The second option is the one canal, one bit of the bifurcation can be obturated by just an injectable bioceramic sealer, like a Ceraseal. Ceraseal means you get something like Metapex tip, where you put the Metapex tip inside and just inject it and bring it out. And then just to ensure that you have equal filling, you can either use a lentulospiral or you can even use your endoactivator. You can just use your endoactivator inside so that the bioceramic is evenly spread. And then the other canal you can obturate in a conventional manner by using a Gadapacha. I hope I'm clear.
Yeah. So, one more question. So, how do you locate the position of MB2 in a second molar in severely calcified cases? Sometimes MB2 is located near MB1,
Hmm.
and sometimes it's a short distance away from MB1. How do you decide where to trough?
That's what I told you. You start your troughing from the mesiobuccal and go up to midway. Midway. At any point of time, the MB2 will not cross the midline. You just imagine an imaginary midline. There is you from the buccal to the lingual. You draw a midline. See what is MB mesiobuccal. So it has to be in the buccal half. It will never go to the palatal half. So you start the troughing from the mesiobuccal and go midway up to middle. So between that mesiobuccal and midway, where you're getting the catch is where you'll get the MB2. Sometimes you'll get it very close, sometimes you get it really far. That's why I showed you two cases. In the first case, what I showed you, it was very close. In the second case, what I showed you is almost at the midline. So
Okay.
up to the midline, you need to trough.
Okay. How often do you use CBCT to diagnose MB2?
Never, never. To be very frank, as of today, with due respects to all the oral medicine people, CBCT in endodontics has zero value because I have not diagnosed a single vertical root fracture in CBCT, which I am able to diagnose with my microscope.
Microscope.
Because I mean, with no harms. Why? Because the voxels what CBCT what we you have is only about 70 to 75 voxels. But to diagnose a CBCT, you need higher voxels. So probably the machines in the future will be capable of diagnosing it. But as of now, all the machines which are having 70 to 75 voxels does not have the capacity to diagnose even a vertical root fracture. So there are so many cases where CBCT doesn't show an MB2, my microscope shows, we can able to trace it. So I don't believe in CBCTs at all. Where CBCTs are helpful, probably to know the extent of the lesion, to know whether you need to do a surgery, to know whether you need to do a cyst, how much of bony expansion is present. Only there it is more on the periapex. Inside the canal, inside the anatomy, CBC2 has zero value.
Okay, I think that's the question you have. But there's something that, I just wanted to remind you. Ma'am, a long time ago, I mean, when we did that symposium, I mean, we had a panel discussion. I don't know whether you remember Narasimhan. And he made a statement that if the Gatapacha cone is synchronized well along with the root canal with a very good sealer, that should be enough. There were fellow stalwarts in the. He was the youngest, like he mentioned. He just, I mean, is just off the boat. And everybody jumped. Oh, it's a single cone obturation is all rubbish, and there was a big argument on it. But look at today. I mean, whatever you said is like golden words. It's come true with bioceramic sealers, and the same person who dismissed this idea, and also reciprocal endodontics instrumentation are fielding the same thing. So it's fantastic to see. I mean,
I
what
was
your thoughts
always
are.
I was always a real favor of reciprocation. Not today. In the year
Yes,
2007,
yes, yes,
I used to
yes.
always love that endo cursor. People used to laugh at me.
Yeah.
People used to say, how can you reciprocate something inside the canal? Today, the same
Yes.
reciprocation 1:1 handpiece which I've used in 2007 is now becoming like a
Yes.
hot seller now.
No, I think, yeah, I mean, Madam and me, we always use that TPR10 from NSK where you use
Yes,
your regular hand
yes,
files. And I
exactly.
think I think Courts Davangere, Vasundhara Madam, it was named after her. Did you know that? There's a small interesting, her handpiece was called Vasundhara for India. So
Oh,
it
okay.
is fantastic. And we still use it. I use it for calcified canals. I am
Fantastic.
very happy.
Yeah,
Fantastic.
correct.
And it's just cost about 10,000 bucks versus
Exactly.
the reciprocal machine, which costs 1.5 lakhs. So it is
Exactly.
very interesting to see where we started off. Anyway, that is so clear. I think there is one more question. Sorry, we
No
have two
problem.
more minutes. I'll just finish this. Uh, so, an electronics tips are. Ruchika, can you read that please for me? I'm not getting the whole thing. So he says his alternate ultrasonic tips are expensive. So he tried with the burr in slow speed on extracted teeth. So he was able to tough and locate it. Any disadvantages to use a burr over this? I think that's the
Very,
question.
very risky. Very, very risky. Use a burr. If you're using it, you have to be very cautious. Cut the water completely and slowly, but it's very risky, extremely risky. But it's actually not very expensive because if you get a good quality ultrasonic tip, see my ET20D, my StarTex 3 lasts almost a couple of years. So many patients you can use it. Good quality ultrasonic tips last good. Only thing is you have to be careful with the power settings. The power setting has to be never more than 5. Okay, you have the Acteon machine. In that, don't go beyond 5. If it is going to be diamond coated, it's 3.5. And if it is going to be like thin for instrument retrieval, it is between 2 and 3. You stick on to this power setting, you will not lose your tip. Your tip will last a
And
lot.
and all the cuttings are dry, right? What you recommend
Dry,
is
dry,
dry.
dry, dry. Absolutely dry.
So there's
Okay.
another
Last
Absolutely
question.
dry.
question of the day, I think, because we are due for the next lecture. In certain cases, MB2 is absent. How can we be sure about the absence of MB2 without cutting more dentin?
That's what I told you. No, it generally if the volume of the MB1 is pretty large, if you feel that the mesiobuccal is pretty much bigger, almost the same size of the distobuccal, even then I do trough a little bit. I just trough a little bit. You can see that the isthmus will be very clear. It will not go deeper. So in that cases, you can be very sure that there is no MB2.
Okay. So that comes to the end of the first session. Any other questions? Please forward it to us on the WhatsApp group, and we will mail it to you guys personally to Dr. Nasiman, and we can coordinate and giving you the answers. Dr. Nasiman, I think that was fantastic. Like Meena Madam had told me and Ramya Madam told me, your concepts are very clear. And one thing that both of them have told me that once you listen to your lecture, the concepts are very clear for any student. I think including me, and that is fantastic.
Thank you
We're very
so much,
happy.
Ashish.
I
Yeah,
hope we can collaborate with you many more. Ma'am, you want to put in a word?
yeah, yeah. Dr. Narasimhan, that was simply stupendous. Your presentation style and the clarity of thought and the clarity of concepts. That is something that I really have to appreciate. I've been a teacher for so many years, nearly 30 years. But you come across as one of the best teachers that I have ever listened to. And
That
I'm
is that
sure
is
today's postgraduates who have listened to your lecture are immensely benefited by your presentation. There's a lot of information that you've given and a lot of clinical tips from your own personal experience. And that is something I really appreciate and thank you for. Hope to see you again in our future forums also. Thank
Thank you
you.
so much for
And
your
more than
words.
anything, Dr. Narasimhan, I've known you for so many years. I think I met you first when I came to your college when Dr. Parameshwaran was there in
Yes,
2002. And,
yes,
Dr. Karthikeyan, I remember, told me
yes.
that, here is a brilliant student and you stand across as a brilliant student. for life. Thank you.
Yes.
Thank you.
Thank you so much, ma'am. Thank you. I'm
Thank
Also,
honored.
you.
you were recommended strongly by your teacher, the legendary Dr. Parmeshwaran, and I mean, you've never disappointed us. So don't change. Many more success
Yeah.
to you, more power to you.
Yes,
All the best.
yes. And
Thank you,
yeah,
ma'am.
and
Thank
one
you.
more thing, Dr. Narasimhan, you come across as a very warm, very friendly, very down-to-earth person. And I'm really glad that we had you this time. And I'm thankful to God that, He made it possible for you to join us this time. Thank you
Thank you,
once
ma'am.
again.
Thank you so
Thank you,
much, ma'am.
sir.
I'm really
Thank
honored.
you.
Thank you, Ashish. Thank you, ma'am.
Yeah.
Thank
Okay.
you.
Monica, over to you.
Thank you, sir. So that brings us to the end of our session. Now, before we move on to the second lecture, we would like to share a very important and exciting news with all of you. Next week, we have the masterclass finale, where we are ending the series with two grand programs. We are very happy to share with you we have two world renowned speakers, clinician and technician amongst us. We call it the Masters of Aesthetics. All of you, of course, know Jordi Magnotta from Stylo Italiano and Nasi Shademan, the world famous ceramist and a technician. So, this is a fantastic news for us. I am very happy to share this news with all of you. We will be announcing the dates and dropping the brochure shortly. Please note that these two talks will be on Zoom platform. Please do join us in this. Now, moving on to the second lecture of the day, I would like to invite our dear HOD ma'am, Dr. Ramya Raghu ma'am, to come and address the second speaker for the day. Over to you, ma'am.
Yeah. Good afternoon, everybody. I'm sure you had a wonderful time listening to Dr. Narasimhan. We're going to have another interesting and very informative session with Dr. Rajesh. I'm very glad to introduce Dr. Rajesh Pillai. He graduated from A.B. Shetty Memorial Institute of Dental Sciences in 1994 and obtained his master's degree in endodontics from College of Dental Sciences, Manipal in 1997. He is a certified laser specialist from the University of Genoa in 2013. Currently, he is the professor and head of the Department of Conservative Dentistry and Endodontics at CMS Dental College, Trivandrum, and he is the director of postgraduate studies there. He has delivered several lectures at national conferences and he regularly conducts certificate programs in laser dentistry at his college. He is in collaboration with the European Medical Laser Association. He is also a biomaterial consultant at Sri Chitra Srinath Institute of Biomaterials in Trivandrum. I have personally known Dr. Rajesh for many years, and he is an excellent clinician and an excellent academician as well. He is going to share his vast knowledge about lasers, the use of lasers in conservative dentistry and endodontics with all of us. Over to you, Dr. Rajesh, for your session.
Thank you, ma'am. When it comes from your mouth, I think it adds a lot of, what do you call it, energy into that. And first of all, I would like to thank the organizers of the masterclass for giving me an opportunity. Let me see whether I can do justice to the time frame because the matter which comes under these two headings is enormous. Okay. See, at the outset, what makes laser a bit different from ordinary light is laser is nothing but it's a form of electromagnetic energy, which is basically contains photonic corpuscular elements with a bit of energy. How laser is unique is because it has got primarily four properties. It is coherent. That is, almost all the individual energized particles are in phase with each other. They are monochromatic. They are monochromatic. Monochromatic means each atoms or the energized photons are of the same energy. They can be fine focused into a particular area and get the job done, where a precise ablation can be done. Then there is something which is known as collimated. Collimated is nothing but all the individual laser rays are parallel to each other. See, this word laser is nothing but an acronym which stands for light amplification by stimulated emission of radiation, which was coined by Dr. Gordon Gould. If you see a little bit of history of lasers, it was in the year 1917, Sir Albert Einstein, who first coined the term stimulated emission, which I'll be mentioning a little later. Then, in the year 1958, Charles Towns coined the word maser. That is nothing but microwave amplification by stimulated emission of radiation. Then in 1957, it was Gordon Gould who first thought of the concept of lasers. Then in 1964, Charles Towns and Arthur Shallow won the Nobel Prize. Then in 1961, Nitzer introduced the first, what do you call it, the NDR laser. Then in 1965, Patel and co-workers introduced the carbon dioxide lasers. Then in 1985, right, Myers and co-workers introduced the first quartz fiber energized laser machines, which could fit into any part of the oral cavity. Then in 1989, which was indeed a revolutionary invention by Hibbs and Keller at the University of Hamburg, Germany, where they invented the heart tissue lasers by name erbium yak. If you see, many part of the life have been touched by the laser rays, be it a laser show, rock show, our DJ night parties, even your what do you call it, laser printers, what we see in the margin-free supermarkets have lasers of different types. The Federation Denture International had approved diode lasers as well as the erbium lag lasers for a variety of surgical procedures, which I am presenting in a nutshell, where it can be used for most of the soft tissue surgical procedures. Whereas, even though the erbium lag lasers are known under the name hard tissue, it can be used both on soft tissues as well as the hard tissues. Whereas in restorative dentistry and endodontics, we have the use of erbium lag lasers more in practicality. As I mentioned this, the ordinary light is of many colors. It is of many colors. For example, the video, they're non-collimated, they are not parallel. They scatter in different directions and are highly unorganized. These three are the primary properties of monochromatic. They emit a wavelength of single wavelength. Collimated, parallel, coherent means they are in act as synchronized phase of the light rays. Okay. See, when you buy a machine from the manufacturer or from the dealer, what does it have? First is the optical cavity. For example, diode laser machines, have you seen, are very, very compact. Inside the optical cavity, it has two reflective mirrors. One is fully reflective and the other one is partially reflective. For example, on one side, if it is 100%, and on the other side, if it is 85%, the balance 15% of the laser energy gets leaked through the optical quartz fiber to the terminal end of the handpiece, where it can act against the substrate. Next one is the active medium. What do you mean by the active medium? Active medium is the primary source from which the laser energy is generated. For example, the diodes. The diodes are basically semiconductor diodes. Then you have gas-based laser machines like carbon dioxide, argon, helium neon. Then primarily how the hard tissue lasers are being manufactured by the commercially. For example, if it is erbium yak, the pure yttrium aluminum garnet crystal is being intentionally contaminated by the erbium so that it produces the laser energy of a particular wavelength. The pumping source of a laser machine can be either an electric coil or a highly energized flash lamp. Then controller. Controller is nothing but it is like a software program which control where the operator can set the modules, pulses, frequency, the wavelength, as well as the pulse duration also. And also the type of laser energy which emanates from the tip of the handpiece. Then you have the coolers. They are inbuilt fans which prevents any buildup of the heat inside the chamber. Delivery system. See, delivery system, you have different types, I think. There are articulated arms, which are really cumbersome, which are in the case of carbon dioxide as well as erbium laser machines. Whereas when the diode lasers really became popular with the, what do you call it, the people who practice frustrated dentistry and endodontics, they preferred miniature quad-sized hollow fibers, which can be delivered to the surgical substrate at the diameters of 200 or even 320 microns. Then you have compact handpieces, which have a small outlets through which the quartz fiber usually emanates. So, what are the basic laser tissue interactions? One is absorption, which we primarily take into consideration, for example, in a gingivectomy, gingivoplasty, where the laser energy is absorbed into the soft tissue or for a hard tissue. This actually emanates primarily in a combination of light as well as heat, which can be called as the photothermal mechanism. So, for any laser to be effective, it has to have a particular chromophore which has affinity towards that particular wavelength. For example, the diode lasers, they perform excellently in soft tissues primarily. So, they have to have either hemoglobin, melanin, keratin inside the soft tissues for these laser wavelengths to be absorbed. So, what happens is there is initially buildup of heat inside the tissues, followed by coagulation of the proteins and removal of the tissue by vaporization. So this is of utmost importance as far as soft tissue lasers are concerned. The second most important property is the transmission, where the laser energy do not have any effect with the substrate and they generally pass out, because most of the diode lasers do not have any effect on the enamel and dentin. Scattering. Scattering is of utmost importance, as that is all internal scattering is of utmost importance in bleaching, where the particular pigment which is present inside the bleaching gel absorbs this laser energy, whereas two mechanisms happen. One is a small buildup of heat inside the bleaching gel, and the heat is being scattered inside the bleaching gel in all directions to give a circumferential effect. Then reflection. This is actually speaking an unwanted effect where the laser energy bounces off the substrate. That's why in most of the laser undertaken surgical procedures, you need to wear protective eyewear for the patient, the doctor, as well as the nursing assistant who is involved in the procedure. For most of the diode lasers, which are highly penetrative, we have to use pigmented glasses. Whereas the erbium YAG as well as the erbium chromium YSTG lasers, we need to use transparent glasses, where the depth of ablation is not that very well. As far as a postgraduate student is concerned, an examiner can ask you, what are the thermal effects on the dental soft tissue? See, if you see a temperature range of 37 to 50 degrees, that is where the initial buildup of heat takes place and primarily the inactivation of the bacteria takes place. At a temperature more than 60 degrees, there is protein coagulation as well as its degeneration. Between 70 to 100 degrees centigrade, that is where the crucial mechanisms like welding of soft tissue as well as the contraction of the wound edges take place. Whereas in soft tissue, there is a procedure what we call as ablation. Ablation is defined as the removal of any soft tissue by vaporization. Okay, and beyond this, all are harmful effects like carbonization, melting, tissue charring, and especially when you are using hard tissue lasers, it's like a meltdown. Then also, 5 types of biological effects do occur when the laser photons enter the tissue. One is fluorescence. Fluorescence is nothing but very useful in what do you call the caries excavation, as well as the detection of incipient occlusal caries, smooth surface caries, as well as the proximal caries, which are not normally visible to the naked eye of an operative dentist. So it is nothing but the absorption of a larger wavelength and emit a smaller wavelength in return. Photothermal, of course, in almost all the soft tissue surgical procedures, in bleaching, as well as in photobiomodulation, it's very, very useful. Photodisruptive. Photodisruptive is very, very applicable in heart tissue lasers. In heart tissue lasers, for erbium, we add the affinitive chromophore inside the heart tissue is water. Whereas for erbium chromium YSGG, it is the carbonated hydroxy at the time. That's why these two lasers find an amplitude of or variety of uses for most of the restorative application. So what happens is when the erbium yarn energy is incident on enamel or dentin, it creates small explosions inside the enamel prisms as well as the orifices of the dentinal tubules. So creating a depth of ablation up to 3 to 5 microns. Whereas photobiomodulation, this has picked up recently in low-level laser therapy. This is nothing based on Arndt-Schultz law. In higher power, the laser ablates or removes tissue, and in lower levels of laser energy, it stimulates the repair as well as the attenuates the level of inflammation. In photobiomodulation, you use at very subaplately level, for example, 0.2 to 0.3 watts. For example, applications in endodontics is one is treatment of apical periodontitis. Second one is you can treat a soft tissue surgical wound 24 hours later after the first incident of root surgery. Then maybe an inflamed gingiva. You can even use it to treat a sinus plant. You can even use to treat the tender attached gingiva next to a periapical abscess also. Okay. Repeat again. The heat from the laser expands the interstitial material in the cell until it explodes, clinically referred to as ablation. Very, very applicable, especially for the soft tissues as well as the hard tissues. PGs can make a note that the lasers, when you mention any classification, how is it classified? It is based on the active medium, which actually helps in developing or generating the laser energy. For example, solids, erbium, erbium chromium YSGT, as well as neodyme NDR lasers. Then if gas is the primary active medium, they are particularly named after the active medium, like carbon dioxide and as well as argon lasers. Then liquid-based dyes, excimer dyes, as well as the semiconductor-based dyes, which are known as by the name diode lasers. This is in a nutshell. I'm just showing you the different type of lasers based on their clinical application. So you have, I will show you the primary, which are of, one is the diode, 445 nanometers. Then KTP, that is frequency doubled potassium titanyl phosphate laser, which emanates a wavelength of 532 nanometers. If somebody is asking you, which is the best laser to give you the bleaching effect, is the KTP lasers, followed by the diodes as well as the erbium YAG lasers. Then you have the carbon dioxide lasers, which is an excellent soft tissue laser, as well as a hard tissue laser. Now it's slowly making a comeback. Hard tissue, of course, the jack of all trades, can be used literally for any soft tissue as well as the hard tissue applications. Now, as I have told you, the diode lasers are used extensively in low-level laser therapy. For example, the 810, the 940, 970, as well as the 1064 nanometer lasers. Then you have something for caries detection also. The Sirona company have marketed a curing like device which resembles a portable LED like device known as Sirona Select, which emits a wavelength of 405 nanometers, where all the damaged tissues or the infected dentin is shown as red, and the other intact areas are shown in varying shades of violet and blue. It is known under the acronym FACE, that is nothing but fluorescence assisted caries excavation, and you have the diode lasers, which are popularly marketed under the heading Diagnodent, as well as the Diagnodent pens also, which emits a helium neon laser, by the wavelength 655 nanometers. The first one, what I'm showing you is the AMT plus lasers, which are marketed by the Densfly. Densfly. They are, one is AMT basics and AMT advanced. Then this is a light waveguide laser marketed by the erbium YAG lasers marketed by Photona, which has got two wavelengths. One is an Nd:YAG lasers on the left as well as an erbium YAG laser on the right side. Then these are the tips, where one is 200 microns tips, which is color-coded violet, and the other one is 300 microns, which is color-coded orange. And you have even, along with a company like BioLis, you have even disposable quartz fiber lasers, okay? Whereas after one use, you're supposed to throw it off. Then you have a erbium YAG laser machine, which emanates a working length of 2940 nanometer. Primarily, they contain a wavelength of 2940 nanometers. If you notice at the end of the bottom of the slide, you have the detachable erbium YAG slides. They are primarily made up of fluoride glass. Okay, fluoride glass or sapphire tips comes under various diameters of 400, 600, and 800 nanometers also. And on the extreme top here, you have thin fiber tips. They are known as radial firing tips, which were initially tried for shaping of the root canals, where the results were pretty disappointing. And on the top left side, you have a machine which has come into the market recently by the name Zerona Blue. The uniqueness of this machine is it emits three wavelengths from the same machine, that is 445, 660, and 970 nanometers. The wavelength 445 nanometers is primarily used for all soft tissue surgical procedures, whereas 660 nanometers are used for biostimulation procedures, whereas the 970 procedure is primarily used for decontamination of the pulse space. There are three types of wavelength, especially for a laser machine. One is a continuous mode, which means that once you switch on the foot pedal, the machine is emitting laser waves continuously. The biggest disadvantage of this particular type of emission is it doesn't give time for the tissue substrate to cool down because of the continuous reception of heat energy. So there is something which is known as thermal relaxation time, which means nothing but you have to have a time where the tissue substrate should be able to lose 50% of the thermal energy it has received. Whereas in the pulse mode, an inbuilt gate or a shutter prevents the free flow of energy. For example, if I am delivering a wattage of 1 watts to the substrate, actually the surgical substrate is receiving only 50% of the energy which is displayed on the panel. The third one is only in cases of an erbium YAG lasers, it is known as a free running pulse mode. Because the free running pulse mode has got a very short span of life, say for example 50 microsecond or 150 microsecond, where these lasers achieve a high peak within a short span of time. That is, from the excited state, they come down to the ground state in a matter of microseconds. Okay. For any laser energy to start functioning, that is a soft tissue surgical procedure, you need to initiate it. Plus, on the left side is a quartz fiber where you need to contain or you need to deposit a small layer of carbon at the tip of the fiber. That is nothing but you don't want any energy dissipation. You want most of the laser energy to concentrate near the tip. For example, if I'm doing a laser assisted tissue retraction, gingivoplasty, gingivectomy, okay, or if I'm sculpting a marginal gingiva for a class 5 restoration, I need to initiate the tip. Whereas if I'm doing a decontamination of the pulse space, I will not initiate the tip because I need some amount of energy to spread laterally into the dentinal tubules. On the right side, you have a carbon dioxide laser, which needs to be initiated by immersing the or an erbium YAG, which needs to be inserted by immersing it in water, which serves as the primary chromophore. Okay. As I mentioned this, one is lasers can be used in contact mode as well as a non-contact mode. Be informed that the diode lasers work in 95% of the cases in contact with the tissue substrate, except when it is performing low-level laser therapy. And most of the erbium YAG lasers, erbium chromium YSGG lasers, or the carbon dioxide lasers function in non-contact mode. That is, it is kept at an optimum distance, say between 5 to 10 millimeter away from the tissue substrate, where you get the maximum codes. This is for a postgraduate student, very, very important. It is known as COATS. It is known as clinically observable ablation threshold, where you get the sound of a popcorn popping out of the machine. Okay. Okay. Then this is the scissors which is readily available along with the diode laser kit, where you need to cleave the tip. That is, after one or two uses, you need to cleave the outer layer of the quartz coating, which is nothing but a rubber coating. Where, and once you activate the machine, a clear comet tail should be present at the tip, I think, without any carbon residues. That shows that the laser is ready for firing. Okay, contact mode. The distal end of the fiber tip is placed in direct contact with the target tissue. For example, here I'm using it to perform an act of frenectomy. And whereas on the right side, I'm using a carbon dioxide laser in a non-contact mode for the same purpose. Then, first of all, starting with the topic laser-assisted caries diagnosis. In the year 2004 or 2005, the Carvo people had marketed initially the Diagnodent kit with the claim that it could even detect demineralization of the most incipient caries lesion up to a depth of 30 microns. So it was something like a flat handpiece. Then the second generation, which is known as Diagnodent pens, came into being, where it could explore the interior of it can access the fissures as well as the interproximal areas. Okay. So this is how, can you see the bottom reading? On the left side, it gives you the normal range parameters. And on the second side, it gives you the depth of the carious lesion. For example, here on the bottom, you can see what are the various caries. It is primarily based on a British system of caries assessment. That is 0 to 10 gives you healthy tooth structure. Then 11 to 20 means that the caries is just on the outer half of the enamel caries. 21 to 29 shows you it has reached almost the inner half of the enamel, maybe bordering the dentino-enamel junction. And the 30 plus values means it has literally penetrated the occlusal surface. So you can call it a non-ablative laser light emitted at 655 nanometer, where the light is directed towards the occlusal surface. What happens is when the light is directed towards the occlusal surface, it gets absorbed through the enamel, where the bacterial byproducts, for example, porphyrin, because most of the chromogenic bacteria or the acidogenic bacteria have chromophore in their cell wall. So this porphyrin gets absorbed by the bacteria, and in return, as a return gift, they emit a bright fluorescent red light, which gets absorbed by the receptors in the machine, and the value gets detected on the right side. What are the merits? Or any machine, if somebody is asking you, can you tell me 3 merits of the diagnostic machine? Is one is high sensitivity. High sensitivity is the ability to identify the true positives. For example, if I'm subjecting a clinical examination of 100 teeth, and if 30 teeth are turning out positive, that it either warrants a placement of a pit and fissure sealant or a flowable composite or a microhybrid composite or even an amalgam. It shows you that it has got high sensitivity but lacks in specificity. That is, it lacks the ability to give you the true negatives. It is highly useful in predicting the depth of the caries. For example, if I show the value shown is 40, means you can assess that it has reached the outer third of the dentate. So you can make a mental picture of the depth of the cavity preparation that you are able to undertake. Then also, it helps you in assessing the demineralization of smooth surface areas, especially the buccal third or the lingual third. Contrarian thoughts. For every researcher or an academician, you have to have and be able to identify the contrarian thoughts or the demerits in any mission which is considered highly popular. Okay, if you say the demerits, one is it is not able to assess the remineralization of incipient lesion, which is a very arduous task. Then sometimes the second point I will show you a picture, sometimes inherently because of your diet, some people do have dark or brown spots on the occlusal pits and fissures. They can overscore or show you over-report the areas of demineralization. Then any small remnants of plaque in the pits or fissures or in the areas just below the contact area or any remnants of dentifrice or the toothpaste residues or even can give you false positives. Then one interesting reading I found from the Journal of American Dental Association in 2016 was, if you place a white color pit and fissure sealants, maybe if you examine it after 1.5 years, and if you subject that pit and fissure placed to a helium neon laser light of 655 nanometers, some small pigments which are present in the pit and fissure sealants can fluoresce in the when it gets exposed to a laser light. So it can give you false positive because of the intrinsic fluorescent nature of some components which are present in the pit and fissure sealants. See, I've told you here again, the dark spots, this can overscore or over-report the depth of demineralization. Then something a case of occult or a hidden caries, where clinically when you see, you just see a small shadow of brownish appearance which goes from the edge of the marginal ridge to the cervical area, which gives you a doubt that this close contact can hide proximal or proximal cervical caries. You make a small opening with a pilot burr, which gives you a small image of a hidden proximal caries, which would have gone unnoticed on a normal visual or a tactile exploration. This is the clinical picture at the end of your very conservative box preparation given at the end of a cavity preparation. Then regarding what do you call, this article had come from Turkey, from Oswald Belgin, and it is actually a position statement that gives you the status of laser-assisted pitch and fissure sealing. And they have mentioned the effect of different techniques of enamel etching also on the shear bond strength of pitch and fissure book. And it is a must read, and it has come under the article Laser Photomedicine in the year 2007. Okay. In a nutshell, when you speak, erbium lasers can be used for three purposes. Please take a note, three purposes. One is it can be used for preconditioning the healthy pits and fissures. For example, non-ablative mode actually. It is just used to decontaminate the pit and fissure before a pit and fissure sealant is placed. You can categorize it under the category non-invasive. Then something is there as minimally invasive preparations where the erbium YAG lasers can be used to decontaminate the deep fissures, followed by the opening up of the orifices of the fissures. Then the minimally invasive ablative technique, which can be used to treat the white spots or the early signs of incipient caries. On the left side, you see a view of a mandibular third molar, which has been extracted and examined closely under a magnifying glass, where you have, other than the primary group, you have the radiating pits or fissures, which gives it a very complicated anatomy. This is the examination of the scanning electron microscope, where you have a narrow fissures where you can closely assess. When I'm again taking the magnification up to 9 times, you have certain areas where an incipient demineralization has happened, where the normal toothbrush bristles or the self-cleaning aids cannot reach. So this actually warrants the need for a placement of a pit and fissure sealant. Okay, here we're using an erbium YAG laser First one is the decontamination mode, where I'm using a 30 millijoule mode, where I'm using 0.5 watt with 60% air, 70-80% water flow, where I'm just mildly opening up the pits and fissures here. So you have a small mottled appearance here, and in certain areas, I have opened it up to dentin, where you can even see the layers of dentin, where the black arrows are being denoted. Then followed by the placement of the pitch and fissure sealants. And mind you, whenever you use an erbium laser or an erbium yard laser, it is not held at a 90 degrees to the occlusal plane. It is held at an angulation of 25 to 40 degrees. That's where the maximum ablation or you get a breach in the enamel prisms do take place. Okay, this is for the general purpose. I'm not going to read every content of the one is for healthy fissures. So you can see the value, it's between 0 to 10, and I'm using a minimum energy. That is, and also the 20 hertz. Hertz is nothing but the frequency where the erbium yard machine is on, switched on. That shows you the number of repetitions per second. Okay, and high water, air water spray and short pulse duration. Whereas, what is the difference that has happened when I've gone on to the affected, where I have slightly raised the ablation energy to 200 millijoules and also raised it to 50 millijoules. Whereas when I am coming into dentin, I am going into a more reduced energy. Why? Means dentin contains around 10 to 25% water by volume, as well as the infected dentin is also highly water containing. That is, it contains around 24 to 40% water. So, as you have the affinity chromophores available, you need to go for a reduced energy signal. That is, you reduce immediately to 100 millijoules. And this is again a revolutionary thought. That is a carbon dioxide laser emanating at a wavelength of 10,600 nanometer. One is it can be used to melt the external surfaces and cause a refusion of the affected pits and fissures. So you avoid the placement of a pit and fissure sealant, and this as part of a preventive or operative dental procedure, you can use it to seal the external enamel surfaces. What are the advantages? One is it improves the enamel resistant against recurrent acid attack, and it transforms the carbonated hydroxyapatite to less soluble. And also the absorption characteristics are highly matched to that of the calcium phosphate present on healthy enamel. And also one technique which has become very, very popular in the year 2006 and practiced with an 810 nanometer diode laser by Samapurna is at the time of administering APF gel, if you can subject it to a duty cycle of 2 duty cycle spanning 20 seconds at 2 watts, it can improve the fluoride uptake by enamel. Coming to one of the most interesting portions of the restorative dentistry, now you have a laser assisted cavity prep. So these are the general. I'll tell you the most important thing. One is no non-contact mode, and you don't get to hear that alarm or loud alarming sound of an aorta, and you can enjoy the precision by sight and also the clinical application. When you compare it to a high-speed handpiece, it's not very fast as compared to a routine aorta handpieces, and it is highly less painful on dent. Then operative application is one is it is end cutting only. It doesn't cut laterally. And unlike an aorta handpiece, it exerts a highly bactericidal effect because most of the bacteria gets removed in the initial 20 seconds of application. Then it produces a clean surface because of the successive pouncing of the enamel as well as the dentin surface by a spray of water. And no micro cracks do develop at the surface of enamel and dentin unless you don't follow the parameters. I'll show you in a nutshell What are the clinical parameters for both erbium, chromium, YSDT and anterior T? One is for enamel ablation. I'll just mention only the erbium react. One is 200 to 250 millijoules. Then dentin it becomes almost half. That is, it comes down to 120 millijoules. For dentin decontamination, that is, you remove the layer of infected dentin before you place a material like calcium hydroxide, MT or pyridentin, you are again reducing the energy setting. Then caries removal on enamel 150 millijoules. Then there is something which is known as enamel conditioning as well as dentin conditioning. Erbium YAG laser etching is not a substitute for the 37% orthophosphoric acid, because unlike the 37 percentage phosphoric acid, which produces predominantly type 1 silverstone etching pattern, this produces a mixture of 1 and 2 or a predominantly a type 2. These are the clinical parameters for posteriorly with minor variations. Okay. Then what are the merits of lasers in restorative dentistry? The primary heading can be one is safety, comfort, painless, patient acceptance, especially the pediatric patients. Then, as part of minimally invasive dentistry, it can be used to remove the carious tissue, the decontaminating effect, and also it produces a macro retentive surface, unlike an aorta. Then the temperature rise on the surface of enamel or dentin is less than 1.5 degrees centigrade. The postgraduate students may know. Then, in the case of direct pulp capping procedures, what is the biggest advantage is it has a decontamination mechanism. That is, it removes the bacteria in and around the exposure sites and produces a biological wound or a coagulated layer of blood action, coagulated blood layer at the site, so that it seals the site of exposure, followed by a layer of calcium hydroxide or MgU. Then also, without much bleeding, you can expose the subgingival tissue margins during your cavity preparation. Okay, this is a clinical scenario where I'm preparing a very conservative class 2 MO cavity on 2.6. At the clinically outset, under a magnifying loop, I can see small micro cracks radiating onto the margin ridge, undermining the healthy occlusal enamel. So mentally, I have decided to go ahead with a very conservative, rounded off boxes. Here, the energy settings, what I have used is 3 watts, 150 mg on enamel, 75 mg once I reach the dentin. And also what I can do is just to create a contour of the axial wall, I can even take a rest from the adjacent tool and angulate the fluoride glass tip onto the axial wall, where I can selectively apply the affected dentin without causing any discomfort to the patient. And not much of occlusal extension has been done in this case, where it is a conservative case of management of the wear and fracture of the incisal margin, where I have used the enamel accessing parameters on where I have kept the, what do you call it, more mottled appearance with minimal tissue removal to clear, clean, decontaminate, as well as the disinfect. Whereas, as you all know that the lower premolars are highly prone for abstraction lesions. This you have a plus a cervical decay. So here I have used parameters of 1 to 1.5 watts, which has been used to clearly ablate the affected enamel as well as the infected dentin also. Once the caries removal is done, you have a small mottled appearance inside the periphery, which will help me to give a chameleon appearance of the restoration. And also, please do note that there is no over preparation in these type of cavity preps with erbium YAG. This is again another case where a cuspid is affected by a
Dr. Rajesh, you're muted.
Is it okay now?
Yes,
Is
sir.
it okay now?
Yes, sir. Now it's good.
Okay. So this is the next instance where you have a case of abfraction plus a case of class 5 routine aberration. So here the cavity prep has been extended from the abfraction lesion onto the class 5 lesion, where at the end of the ablation procedure, you can get a mottled appearance. Plus, this is a microhybrid composite, which gives you a camouflage effect. And please note the health of the gingival tissues. Okay. This is again a case of deep class 3 cavity present on a cuspid, where we have taken particular care to remove the caries as well as to manage the layer of infected dentine near the pulp mounds. So I create, once you cut off the water supply, I have been able to create a biological bandage near the deepest area, followed by a placement layer of calcium hydroxide. Over on top of that, a glass elastomer as a liner, plus a stratified placement layer of composite resins. Okay. Here again, a case of shown for a lower premolar, where from a small opening on the distal triangular fossa, you may be able to assess the depth of caries lesion on that panel, where you get a clinical impression that the caries is mostly in the dentine areas, where the parameters are different for the enamel usage as well as the dentine usage. So here you need to place a layer of MTA, glass ionomer cement, as well as a composite resin. As I earlier mentioned, you can use the adjacent to marginal bridge to gather the depth of ablation, and where I have managed to give a small angulation to the axial wall, as well as to remove the layer of infected dentin on the axial walls. Okay. This is again very, very important. For example, you have a lot of patients now who walk into your clinic who are on blood thinners as well as on pediatric aspirin. In such cases, if you use a BP blade, there is tend to be heavy bleeding. And if the physician or the consultant cardiologist is telling you, please, I cannot ask the patient to stop even for 5 days, then the best option is a diode laser, which is economical, where when you see the distal cervical area, you see an area of demineralization. With gentle probing, you can assess the depth of the carious lesion is extending slightly beyond the CJ onto the root surface. So here, I can operate at 0.8 watts continuous mode and carefully do an ablation and a remove. And ideally, if I can give a small bevel on the marginal gingiva, it gives you best aesthetics. And here you can just notice a mild amount of tissue charring as well as the welding of the tissue edges also. The top diagram gives you a preparation following a erbium YAG laser assisted gingivectomy. You can see the difference actually here. One is I have removed a little bone on the as mesial aspect of the interdental papilla and also placed a bevel here. And this gives you a real access to the cervical most part of the axial cavity. The most longevity or the clinical factor that gives you success in class 5 respiratory material is the clinical response of the gingiva to that particular respiratory material. And the parameters followed is, as far as a postgraduate is concerned, these were the protocols followed. Then, coming to laser assisted etching. As far as a laser assisted etching is concerned, still 37% phosphoric acid gives you the best results. That is the type 1 etching pattern, where the core of the prisms are mostly affected, leaving the prism tails and the head intact. In most of the types, when you have done acid etching with erbium chromium YSGG, it gives you a mixture of type 1 and type 2. Because what happens is, as the laser energy gets incident on the substrate, there is a repeated melting and reprecipitation of the calcium phosphate on the surface, giving an appearance of vitrification on the surface. And this is a typical appearance in erbium YAG, where the type 2 silver stone etching pattern is visible, where you have a flat surface compared to a few peripheral prismatic pumps actually. And if an examiner is asking you what is the depth to which a laser assisted etching can achieve is 20 microns. Okay, this is again a case of erbium YAG etching as far as a class 4 cavity is concerned. Okay, we are restored with non-invasive nanohybrid composites. Okay. When we do an acid etching, what was the maximum strength, I think, in laboratory conditions which were achieved with fourth generation composites is on enamel as well as dentinous displays. But when we compare it to laser etching, it's almost 60% down as compared to the values which are normally obtained with dentin. And most of the textbooks tell you that a laser etched surface is infractus in appearance. What do you mean by infractus? An infractus surface means it is fractured and uneven with open dentinal tubules and with more effect on the intertubular dentin, leaving the peritubular dentin intact. How is it achieved? We give small micro explosions at the tissue surface. So what happens is, as the enamel receives these micro explosions of laser energy, there is boiling of water, which is referred to as a combination of mechanical energy and thermal energy, which gives you the ablation. So what happens is, it gives, and ultimately some SEM specimens have shown you the depth of ablation is not that great as achieved with normal acid etching, as well as there is recrystallization of hydroxyapatite and formation of additional calcium phosphate, commonly referred to as vitrification. And also, SEM views have revealed that it gives a scaled appearance or a fissured appearance. And also, in some specimens of dentin, it has given an appearance of extensively cracked and lineage subsurface layer. And also, there are union of craters, which doesn't make it highly favorable for bonding. Okay. At least when you speak about the demerits, we need to have speak about the merits. As far as susceptibility of tooth against acid attack and caries is concerned, it improves the susceptibility of the tooth against acid attack. And it brings about a minute changes in the ratio of calcium and phosphate ratio. And also it reduces the carbonates and pyrophosphate formation. And it creates a remineralization microspaces just beneath the hybrid layer which can trap free ions like fluoride. These two articles are a must read for the academicians as well as the clinicians. One is Laser of Photomedicine and Laser Surgery in the year 2000 by Kathleen Heil. That's an SEM evaluation of the appearance of dentin following erbium YAG laser preparation and laser conditioning. Okay. Then lasers have been used in the management of hypersensitivity. Both erbium YAG as well as diode lasers have been used. What is very economical as far as a private practitioner is concerned is sometimes the patient complains of pain without any obvious abrasion, abfraction, or an erosion because the coefficient of expansion of enamel as well as dentin varies on exposure to a glass of cold water. In such cases, what can be done is you take a layer of desensitizing toothpaste, apply it on the cervical third, and you take a 980 nanometer or an 810 nanometer diode laser. If you're going for a 980 nanometer diode laser, you make the setting at 0.2 or 0.3 watts. Then what happens is you keep it at almost 1 centimeter away and in a small circulatory motion, you heat the desensitizing toothpaste in a very mild manner and you drive the desensitizing agent into the enamel pores or dentin, whereby you reduce the permeability as well as you reduce the sensitivity. Whereas even middle output, that is the erbium YAG lasers have also been tried because by protein precipitation and also reducing the diameter of the dentinal tubules. And also they do vaporize the superficial layer of the dentinal tubule. Okay, so these are the operatory parameters. You keep the laser in a non-contact mode at least 5 to 10 millimeter away. As I mentioned, 980. These are the power settings if any clinician is interested. 0.3 watts, the energy that is being transmitted to the tooth is 15 joules per square centimeter for a period of 60 seconds for 3 duty cycles. Then there is something like laser analgesia. Okay, this is especially meant for highly apprehensive patients who have got a fear or a phobia for the prick of the needle. Okay, prick of the needle. So what happens is you go at 0.5 watt to 1 watt at around 30 millijoules. You keep it around 10 mm away from the cervical third for 30 seconds. Then you walk the tip of the laser along the occlusal pits and fissures and also along the cusp thirds, and you subject the tooth to the sub-ablative laser energy. What happens is, if somebody is asking me what is laser analgesia, it interferes with the sodium and potassium pump mechanism, and also it helps the pulpal tissue to retain a state of sustained hyperpolarization. There are two techniques which are being popular and marketed, which are being marketed now globally. One is the rabbit technique, where it is kept at 10 mm away from the cervical third of the tooth. Whereas in the turtle technique, it is even held closer. That is, it is held in the interproximal areas as well as just 3 to 4 mm away from the tooth. These are the beneficial merits. One is photoacoustic effect. It has got an indirect influence on the nerves and the nociceptors, and it has got a diminishing pulpal and soft tissue reactivity. There is a systematic review and published by Ricardo Poli on the topic laser analgesia, how it can directly implicate the restorative dental care. Okay. Laser-assisted pulp capping, a meta-analysis which has come in Journal of Dental Association, American Dental Association in the year 2016. At the outset, two beneficial effects: decontamination and hemostasis, followed by biostimulation. That is, it helps the injured pulp to recoup or regenerate. And also there is better proliferation, migration, and cytodifferentiation of odontoblasts at the exposure site. You can even use both the lasers, 810, 980, or the erbium YAG lasers. Okay, so what happens initially? If the exposed surgical site is subjected to irradiation by a 980 nanometer diode laser, what I will do is the energy settings will be 0.5 watts for 5 seconds. If the pulp is healthy, it immediately coagulates in a matter of 5 seconds. Okay, so small blood vessels at the site of exposure will be sealed, and there is a small biological wound or a scar tissue which is formed immediately. And there is no bleeding or a tissue fluid exudation from that particular site. This is a small exposure which is being managed with the diode laser. Okay. Okay. These are the views of diode exposure, diode management of a small iatrogenic exposure, which is less than 1 square millimeter, where I have used a diode laser at power settings of 0.6 watts for 5 seconds. This is the immediate postoperative view, where because of the special affinity towards hemoglobin in the small blood vessel, it coagulates immediately. And even if any bacteria are left in the vicinity, they are inactivated. Whereas if you are using a erbium YAG laser, you need to cut off the water supply, where I have used a 600 micron tip, 25 millijoules for 5 seconds and at 10 hertz with only air cooling. And immediately in and around the area, a biological bandage is formed. Okay. Animal studies proved that the success rates are really not enhanced when MGA is used along with lasers, because it needs hydration for its final set. So this article says that to bring out the best action from the pulp capping agent, calcium hydroxide is preferred near a diode laser induced biological wound. Okay. So these are the interesting articles I found along while. Gayavani Olivi, whom we had a chance to listen to during the FODA held at Calcutta, he is one of the pioneers in usage of erbium via the laser especially in pediatric as well as in adults. In European Journal of Pediatric Dentistry, he has published an excellent article on pulp cavity, and also Carmentodia in the Quintessence Journal 2008. So here, for a postgraduate setting, I have just mentioned what are the settings, especially with erbium yaglacys. Subgingival caries, especially physically immobile patients who are dependent on blood thinners as well as the aspirin, you can resculpt the marginal gingiva to the most cervical extent of the subgingival caries. And you need not wait for a day as compared to electrocautery. There is around 10 to 15% tissue shrinkage in electrocautery. You need to wait at least for 3 days before you proceed with the class 5 composite or a glass ionomer cement. For laser assisted gingivoplasty, you can proceed immediately. That is again a merit. Okay. This is again a concept, wonderful concept, which is again picking up. What contributes maximum to the success of a fixed processes in the anterior region, especially the metal free? One is you need to have a beautifully reproduced finish line, maybe a heavy chamfer with a bevel or a shoulder circumferential. Then the gingival tissue should be in the best of the health, and the marginal fit of any respiration should not have a gap more than 50 microns. Okay, so what is here is, this is actually a root canal treated tooth, both 1-1 and 2-1. The tooth preparation is done. So before I am using a diode laser for I am placing a layer of gingival barrier, which we use in office bleaching techniques to protect the margin gingiva. Then what we have done is, I have done a setting of 0.5 watts. The delegate's male is in 0.5 watt continuous wave. So what I have done is gently inserted into the sulcus and moved around. So moved around the tooth for a time of 15 to 20 seconds. So what I have done is, I am just removing the superficial epithelial lining of the gingival sulcus, and also I have what do you call it? I have given a small hyperthermia here, where I am just dilated it. And this is the picture of the IPS Empress Emax labial and palatal view and the final view here. These are the different preparations under SEM magnification. One is under diode laser, where you can see the scarring, tissue scarring, which can be removed with the application of 3% hydrogen peroxide. Okay, this is with MDR laser, where the tissue damage is little more extensive, as well as this is the erbium YAG lasers. As far as tissue friendliness is concerned, erbium YAG gives you the best results out. So the depth of penetration of the fiber is 1 to 1.5 millimeter into the gingival sulcus, and small circular movements around the long axis for a time of 50 to 20 seconds. So what are the merits in laser-assisted gingival tissue retraction? The diode lasers remove only the epithelial, superficial epithelial lining from the sulcus, and there is no damage to the underlying basal cell and the connective tissue, unlike the electrocautery or the BP plate. So minimize future gingival recession, which is a highly probable thing, especially when you are using an electrocautery. And also, as soon as you keep the fiber tip parallel to the long axis, then you are supposed to angulate it 10 to 20 degrees into the gingival sulcus and gently move around the circumferentially around the 360 around the long axis. Okay, this is again another view, retraction under putty wash technique. Okay, this is again another view of a upper lateral incisor, where a little bit of resculpting of the distal interdental papilla, that is in connection with the 1-1 also was required. This is immediately post putty wash impression technique. Okay. Then coming to one of the most important uses in restorative dentistry is laser assisted bleaching, in office bleaching. Okay. See, what you need to do is, mild to moderate discolorations can be treated with in-office bleaching technique. In the first step, what you need to do is isolate the tooth under you have to go for a thorough prophylaxis. There is prophylaxis with a pumice polish, remove any coats of salivary pellicle. Then what you have to do is there is a transparent gingival barrier which is available along with the trays. Two bleaching kits are very, very popular. One is with a laser assisted. One is opalescent boost is there. Opalescent boost plus is there. Then one is laser white 2.0, which is marketed by the company Photona. For any laser to be in close contact with the bleaching gel, it needs to have what do you call it, affinity chromophore inside the bleaching gel. That is, one is it needs to have what do you call keratin pigment, which is present in the opalescence boost, which acts as a chromophore. So once you place the gingival barrier, there is an in opalescence boost, there are two syringes which are connected. One contains the activator, which contains keratin, then the other contains 35% hydrogen peroxide. In the second generation, they have combined the activator as well as the hydrogen peroxide in a single syringe or in a twin syringe or a twin cartridge. You are supposed to paint 2 millimeters of gel each. After curing the gingival barrier, you are supposed to evaluate incisively from an incisal view under a mouth mirror whether any portions of the marginal gingiva are visible. Even if any portions of the marginal gingiva are visible, you need to add a small layer of gingival barrier again. So what happens is when you add a small layer of gingival barrier again, you can prevent sloughing. If sloughing is there, hydrogen peroxide is a highly oxidizing agent. It is not very, what do you call it, biased. I think it can create a sloughing or what do you call it, burned out appearance of the edges of the marginal gingiva. Okay. Coming to the bleaching, the power setting, you need to have a higher power setting. Either two power settings can be used if you are going for a 980 nanometer. One is 5-watt pulsed mode or 2.5-watt continuous wave motion. Okay. If you are going for a 5-watt pulsed mode or a 2.5 continuous mode, you can use a bleaching handpiece where a quadrant of teeth or a group of teeth can be bleached at a time. Usually, we place the bleaching gel from the first premolar to the second premolar. Each tool, you have to activate it for 15 seconds. Every 3 minutes, you need to renew the irradiation with laser assisted bleaching. That is, you need to irradiate for 15 seconds. Once you complete 3 or 4 duty cycles, that is a spanning of a total 12 minutes, you can once slowly remove the bleaching gel and have an evaluation. Before you start the bleaching procedure, if you are taking the classical beta shade for comparison, you need to rearrange it based on the value shade. That is, being the most darkest shade will be C4, followed by A4, A3, like that. And the lightest shade is going to be A1. So if you are coming down actually from a shade of C4 to A2 or A3, you are actually reducing the or lightening the shade of the tool by around 5 to 6 shades. Only precaution you have to follow is if the patient is experiencing severe sensitivity, you have to stop the bleaching procedure. During the pre-assessment time, if you have any linear cracks or any class 5 abrasions, they need to be sealed for light cure composites. Okay, you need to seal off all these areas for composites. And especially the Indian patients, you need to warn them that do not dart their tongue forward, or you need to keep a layer of cotton gauze to protect the tip of the tongue as well as for the side of the tongue. And always it is better to bleach one shade lighter than the actual shade, because there is something which is known as a rebound phenomenon. Because in the first 1 week, the tooth tends to bounce back, especially after absorbing the ultraviolet rays from the sun rays. Okay, and also you need to tell the patient to refrain from having highly carbonated beverages or a masala coloring agents. Okay. This is again another case where it was done using an 810 nanometer diode laser, 2.5-watt continuous 3 duty cycles for 10 minutes each. Okay. This is a recent concept which I have not tried. This is sharing just for academic interest. Now, Photona has come out with a novel erbium yard laser assisted tooth whitening method. These are the parameters where they use a variable length pulse, which is quadrilateral in shape. The pulse energy is 40 millijoules and the frequency is 10 to 15 hertz and the power setting is very low. So they will have a session, that is one duty cycle will last for 5 minutes, spanning for 3 duty cycles. Some interesting articles I found on the way, which is of one is by Lawrence J. Wells. Okay. Am I exceeding the timing, madam?
Yeah, so you can take another 5-10 minutes. No problem.
Only I am just focusing on laser as well as one is laser assisted canal disinfection and PIPs
Okay.
also. Then I'll conclude.
Okay. Okay.
So, because it cannot be concluded. Okay. So these are the articles by Roland de Moore. If you remember, he had participated in that IFE in 2002. This is a very beautiful article in operative dentistry, December 2017. Then there is something which is known as a focal bleaching technique. This was, what do you call it, made popular by Dr. Hamdi Hamama from Egypt, actually, where he has placed a small gingival barrier on the labial surface of the teeth without bleaching the tooth en masse. He has made it into different islands where he has just used hydrogen peroxide only in those areas to bring the tooth into a uniform color. Okay, this was published in Journal of Cosmetic Dentistry, summer 2013. Okay, so it reduces the hazards of enamel cracking and infraction, which usually comes with extensive use of 35% of hydrogen peroxide. If somebody is asking you what is the longevity for a laser assisted bleaching technique, it is only 1 to 1.5 years. After that, there is a tendency of tooth to bounce back to its normal state. Okay. Now, erbium yard lasers have been used to improve the addition of fiber posts in the root canals. There is the following parameters were used: 1 watt, 20 hertz, 300 millijoules for 30 seconds. Okay. Coming to the most important part, please understand that the pulse space is a place cul-de-sac, that is a root or map with no endings. The conventional irrigants, that is especially the normal sodium hypochlorite, has got a penetration depth of a maximum of 130 microns. So you need to activate it to reach areas which are not normally accessible by the shaping instruments. Normally, the bacteria can be holed up as deep as 1.1 millimeters deep into the dentinal tubules. So you need an energy which has got a lateral penetration depth up to 1.1 mm. So they have tried different variations of diode lasers. One is 810 nanometers gave them 74% efficacy, and the 980 nanometers gave them 87% efficacy in inactivating E. fecalis, prevotal, as well as bacteroides endodontalis from the pulse space. Okay, so here the rule of the dictum that follows the use of diode laser fibers is: one is you need to enlarge minimum up to F1 cells, and you have to insert the fiber 2 mm short of the working space. Do not take it up to the working length. And you need not initiate the tip, and slightly moisten the canal with either 2.5% sodium hypochlorite, 17% EDT, or 10% citric acid. Okay. Then once you switch on the machine at 0.8 watts, you keep it for 5 seconds. Then you start retracting it from the canal in gentle circular motion. That is to have a circumferential effect of the laser beam, where the dentinal tubules act as internal light prisms and the energy is absorbed as well as the bacteria are inactivated. Okay. So this I will show you a small video of how the laser sterilization is done. So you can just see that the dentinal tubules act as internal walls or prisms. So once the initial duty cycle is done, you give a flush with saline, then again dry the root canal, slightly moisten the canal with 2.5% hypochlorite, and then go for the second duty cycle. So 3 duty cycles are permitted. Why this moistening of the canals with the, what do you call it, moistening with hypochlorite? You should prevent thermal damage or unwanted melting and recrystallization on the surface of the dentinal tubules, which can reduce the addition of your root canal sealer onto the radicular dentin. Okay. Then coming on to the various articles. The first concept of PIFs, that is photon-induced photoacoustic streaming, was introduced at the University of Arizona in the year 2010 by two pioneers. One is Dr. Enrico De Vito and Dr. Mark Colonna. And some of the articles I'm showing here, displaying here, one is in Roots 2012 by Enrico De Vito, Lasers in Endodontics, then section in Journal of Lasers Medical Science. Okay, what are the sequence when you are using a diode laser? What happens is there is a blending of the bacterial membrane resulting in a vesicle or a blister formation. So what happens is when the vesicles do form on the surface of the bacterial cell wall, there is a leakage of the content. So what happens is immediately the size of the bacterial cell wall shrinks and there is destruction of cell morphology. This is the classical PIPS tube, where the outer 2 to 3 millimeter are stripped off like a cigar. Okay. This is the energy settings, very, very important as far as a postgraduate student is concerned. Each cycle will last for 20 to 40 seconds, 20 millijoule, 50 and 50 microsecond pulse, and the power setting is 0.3 watts. There are two tips. One is 400 micron tip with 14 mm, as well as the one has a 600 micron with 9 mm tips. I'll just show you a video which gives you an example of how the pips works inside the root canal. You can see the amount of vibration inside the root. 15 hertz. Can you see the amount of swirling? So what happens is, as you keep the same settings, we didn't change the power, we just changed the tip and the design. And that was a rather large volume of liquid. If we think about the amount of liquid that is inside a canal system, it was maybe 1/1000th of what we had there. And the effect becomes exacerbated with the diminution of fluid. The less fluid, the more pronounced the photoacoustic effect is. So this is basically what happens when it fires. Most of the energy comes out the end just by virtue of the angle that's got, and some of it comes out, smaller. So you get this kind of extraordinary heating of the molecules that occur there, and you get an expansion effect. It's almost like a micro explosion, a tsunami, so to speak, and you get this radiation. The beauty of this was that even though the tip was not placed at the end of the apex, it could be placed farther away from you, and the folks were still seeing far away. As you see, so this is another video where the tip is placed at the orifice and the canal is flooded with sodium hypochlorite. As soon as the laser fiber is illuminated, it creates a tsunami-like wave or a secondary cavitation effects actually. So what happens is certain bubbles collapse. Certain bubbles are formed with the tip forming the center of the sphere. So this bubble has got a lifespan of only 100 to 150 microseconds. So at the end of 150 microseconds, these bubbles collapse, creating a sharing stress on the canal walls and removal of bacterial smear layer. So what happens is this further interaction with the laser energy creates secondary cavitation and additional bubbles, which creates a disinfection effect as well as a smear layer removal effect up to a depth of 350 microns. Okay, these are some good articles by Dr. O.V. Peters and Dr. David E. Jaramillo. One has come in Journal of Endodontics, 2011 July. Okay. In Dentistry Today, November 2012 by Enrico De Vito and Adam Lloyd. Okay. Okay. One is pad disinfection. This I am skipping, okay, because of lack of. One is low-level laser therapy. As I have mentioned, Dr. Lawrence J. Welch is one of the Pioneers of current status of low level laser therapy, where sub-ablative deafen, you can induce the healing of soft tissues. One is acceleration of wound healing, enhanced remodeling and repair of bone. You can even restore the normal neural function following repair, stimulation of release of endorphin, as well as the modulation of immune system. Okay. See, one is if you are a clinician and if you are thinking about buying a laser, if you are a restorative dentist, I would recommend you to go for a erbium family of lasers where you can have a plethora of uses. Something like you can have applications on soft tissues as well as a hard tissue. If you are a periodontist, the most appropriate wavelength will be 810 nanometers or a 98, 810 nanometers, where you can do a lot of soft tissue surgical procedures. But if you want to do a little bit of biostimulation or a bleaching procedure, you can go in for a 98 nanometers. As far as a postgraduate student is concerned, there can questions come as one is critically analyze erbium family of lasers in restorative dentistry. What is PIPS? What is the depth of penetration of PIPS? What is codes? Then, what are the safety measures that you have to adopt when you are using a laser? Then, in this era of blue, what was the most striking picture was the Indian victory at Brisbane among these gloomy years of last 1.5 years. Okay. One is, if I have satisfied at least 20% of the criteria by giving you clinical tips as well as the laser parameters, I am more than happy. At the end of my lecture, I would like to acknowledge my chairman, Dr. P.S. Taha, who has been a towering and looming figure in all phases, let it be academics and phases of encouragement. My beloved teaching staff, Department of Conservative Dentistry, PMS College of Dental Science and Research, my postgraduate students who have always helped me with the search of articles, and Dr. Remya Reddy, who is like a mentor to me, my teacher in Abhishek, Dr. N. Meena, if she is among the audience, and Dr. Murlidhar Rao also, and organizers of masterclass for providing me an opportunity for this presentation. Thank you very much.
Thank you so much, sir. Sir, can you please start sharing the next slide? Yes, sir. Sir, can you please start sharing the screen?
Yeah, ma'am, I'm doing that. 1 minute.
Okay,
I
okay.
cannot see it now. Just got dropped out, I think. Ma'am, are there any questions?
Yes, sir. We'll start the question answer session shortly.
Yeah, ma'am. Ma'am, can you just stop the sharing of the screen? For me, I think a little technical error. I'm just seeing only the audio.
Okay. Yeah, Ruchika. Yes.
Uh, yeah. Thank you so much, sir. It was a very wonderful presentation. Thank you, sir, for showing various clinical applications of laser, the various fiber-based questions. Being a third year student, sir, third year postgraduate student, it is definitely very helpful for me. Thank you again for this wonderful presentation. So on behalf of our department, we would like to give you an e-certificate. Kindly accept it, sir. And so the e-certificate will be sent to your email address. Now we have the question and answer round. So over to ma'am.
Yeah.
Yeah.
Thank you, Dr. Rajesh. That was a very nice presentation. I know the topic is so vast, but you have done good justice to the presentation with a lot of clinical tips for clinicians as well as a lot of informative articles and references for the postgraduates. I'm sure they will make good use of whatever you have presented today. There are some questions from the audience. One is
Okay.
regarding the diode laser. You say that there are different diameters of fiber optic tips that are there. Is there
Yes, ma'am.
any relation between the diameter and the cutting efficiency of these diode laser
Ma'am,
tips?
one is you have to select the diameter. One is 3 points. One is you have to select the diameter of the laser fiber based on the tissue substrate. One is if I'm going for a frenectomy or an operculectomy, I would use a 600 micron tip pack, for example, to connect to an AMT handpiece. Then, if I'm going for a sterilization of the root canal, I'll use a 200 micron tip pack because this depends on the accessibility. Whereas if you want to remove large amounts of tissue, you need to increase the diameter of the laser fiber, which is possible if the manufacturer is giving you the provision for detachable color tips, which are color coded also. I think you remember during
Yeah,
my
yeah.
presentation,
Yes,
there
yes,
was
yes.
a
I watched it.
violet color and orange color tips
Yes,
actually, which were
yes.
present as part of it. Yes, ma'am.
Okay. Another question is, can you throw some light on sweeps? I think we all know of PIPs. So there
Yeah.
is something new called sweeps by laser disinfection. What is that?
Ma'am, it is by using a short wavelength assisted, what do you call it, energy lights to disinfect the pulp chamber as well as the what do you call it, the canals. So here, what they found is the gentle bay window as well as the sweep is very, very expensive as far to purchase for a college as well as for a private practice AAK. These are all emerging new concepts. What they are using is a combination of photoacoustic energy. That is a combination of light and sound, I think, where the bacteria or the resistant biofilms are shared off from the surface of the canal walls actually and removed.
Okay. And another question, what diameter tips do you recommend for crown lengthening?
Ma'am,
For
actually,
couples
either
of-
it can be 200 microns or 320 micron diameter tips are recommended for crown lengthening, ma'am.
Okay. And between the erbium YAG laser and diode laser, which would you recommend for surgical crown lengthening?
Ma'am, actually, I've told you, it's like, what do you call it? In Hindi movies, you can produce a movie, you can make a movie hit by having Imran Hashmi as a hero or as a Salman Khan as the hero. If I have the budget, I will go for Salman Khan. It is something like if I have the budget, I will definitely go for erbium YAG. But if I want to work in an economical way, diode lasers are the best actually for crown lengthening.
Okay. Okay. Thank you, Dr. Rajesh. If there are any more questions, we will just mail it across to you and you can send us back the answers.
Yeah,
And
I hope
one
it
thing I want to say about both the presenters today, they are so passionate about what they are doing and they have given their all to, achieve their success in their chosen domain. So I want all you PGs to take this, take this straight from them. Whatever attributes they have, you take it from them and mold yourself in their line. That is something that I would like to tell all the postgraduates here in this forum, that you have to have your total passion for the subject, and only then you will reach heights. Thank you once again, Dr. Rajesh.
Thank you, ma'am. It was a pleasure. Thank you.
Ruchika?
Yes. Hello? Yes. Ma'am, sir is unable to connect, so can you close the session?
Okay. Before I end this session, I would like to remind all of you that we are coming up with the masterclass finale on starting from next Monday. So the first lecture is scheduled for next Monday, and that is by one of the greatest aesthetic dentists of the day, Dr. Jordi Manuta. He would be talking about simplifying aesthetics with composites. So he has a wonderful technique of layering composites to produce lifelike recreation of tooth structure, even surpassing the effects of ceramics. You know that he's a very popular author. He's the author of the quintessence book Layers. So he is going to join us on Monday. Do join this session. This is going to be on Zoom platform, and there is only limited number of registration for this program. So we are eagerly awaiting his session next Monday. So I hope to see all of you in this session on Monday.
Okay.